My task is to go over metastatic breast cancer, and indeed, before I even had a chance to come up, 2 or 3 old friends and a couple of people I had not met before walked up and said, "Let me give you a case." And my answer usually is, what's your goal of therapy? And if it's to make them feel better, you can pretty much do what you want to do as long as you're balancing how likely it is you'll make the patient feel better with how likely it is you'll make the patient feel worse. So that raises the issue of what are we trying to do with metastatic breast cancer. And while some of the first part of this talk will be pedantic, especially if you've heard me give this talk before, I find over and over again, I see people coming in that I believe have been overtreated because I believe that her oncologist has not really thought through what the goal of therapy is. And either that or he or she has overestimated what the potential goal of therapy is. Now, of course, for our patients, their first thought is cure. I have a couple of my former fellows in the room, and they'll tell you the first time they're with me and we see a metastatic breast cancer patient, I say, "What do you think this patient wants?" And they've always sort of been trained ahead of time and say, "Well, they want to be palliated." I have never seen a patient with newly diagnosed metastatic breast cancer say, "Well, will you palliate me?" They almost always say, "I want to be cured." And while that sounds like I'm making a joke, I'm actually not. I wouldn't say that. I'd say, I want to be cured. The issue is we have actually very little evidence that we cure patients with metastatic breast cancer. I have in the past showed slides from MD Anderson, but I've taken them out, suggesting that of the roughly 10 to 15% of patients that they induced a complete response in using CAF back in the 70s and 80s, about 10% of those remain in continuous disease-free remission for 5 years or more, suggesting that perhaps of those patients who are at least hormone refractory, we cure about 1 or 2%, or at least we keep them disease-free for a substantial longer period of time. In fact, some of those patients probably didn't really have metastatic breast cancer because they didn't biopsy everybody at MD Anderson. We'll talk about that in just a minute. But for all intents and purposes, I think that those patients we do cure, we probably cure almost in spite of what we do and not because of what we do. And there's been no evidence that, for example, aggressive and highly toxic therapy is more likely to lead a patient into being cured than just treating that patient with what makes the most sense to achieve the third goal. Now, there is some evidence that we prolong survival, and if I were writing your boards, I would actually probably ask you something like this. This paper, to my knowledge, has never been published, and that's too bad. I just talked to Steve Chia a couple days ago. But British Columbia is a relatively closed shop, although they have some immigration, mostly from Asia over the last 10 years. They don't have a lot of emigration, and they practice medicine based on guidelines that the Canadian government lays out pretty strictly, and they have a terrific data set. They have a great outcomes program so they can keep track of what happens to patients and how they're treated. Indeed, their guidelines have said not to do screening analysis for asymptomatic patients who previously had primary breast cancer. As Dr. Davidson said earlier, that there's no evidence to do so. And so what that means is that there's probably very little diagnosis drift here. In other words, we're probably not detecting patients earlier if we see a prolongation of survival. It's probably not because we're just finding them earlier. It's probably real. And while I'm not going to show you the data because I'm relatively limited on time here, what they showed was a stepwise increase on about an every 2-year basis from the late 1980s to the early 2000s in patients who had metastatic breast cancer, suggesting that during that time, with the introduction of several new chemotherapies, the taxanes, capecitabine, several new hormone therapies, in particular the aromatase inhibitors and fulvestrant, and then towards the end of the time period, trastuzumab against HER2, they probably increased overall survival by about 20 to 30% of what it was in the early 1980s. So the suggestion is there is some benefit, but it's not huge because a 20 to 30% increase in survival from a median survival of, say, 20 to 25 months still only results in a few years of median survival, and nothing like what we'd really like to have. So I go back to, I think the main goal of therapy when you're treating a patient with metastatic disease is to make her feel better. And I tell my own patients, what we're trying to do, Mrs. Smith, is keep you feeling as good as you can for as long as you can. And that means picking the therapies most likely to work. Means, first of all, making sure you have metastatic breast cancer, then picking the therapies most likely to work, and then assessing whether they are working or not. One of the things that I really make it clear to our fellows is, first and foremost, establish the diagnosis. I rarely assume that a patient has metastatic disease based on symptoms or radiographs alone, and that's because I would guess 10 or 15% of the time I'm wrong when I do so. So if at all possible, I try to biopsy a metastasis. Now, it's not always possible, or the data are just so overwhelmingly compelling. For example, a patient who's got new pain, has multiple bony sites, you take x-rays and they're all lytic, and she's got a liver full of abnormalities. Yes, that's probably metastatic breast cancer, especially if she had breast cancer 2 years or 3 years ago. But if there's any question at all, I make every effort to do a biopsy, and especially if they're pulmonary lesions. And I can tell you that pulmonary lesions have the highest rate of false positivity, and it's really important, I think, to make sure. Second of all is to establish the prognosis. And the reason why is that although my philosophical discussions earlier in this talk are notwithstanding, there are some patients in whom more aggressive and toxic therapy up front probably is life-saving, and those are patients who have rapidly progressive visceral disease. And I would combine those two phrases, rapidly progressive and visceral disease. I have seen a number of women who have been told, you have liver mets, we should bypass hormone therapy even if you're ER positive and go right to chemotherapy because you have visceral disease. Well, that's actually not appropriate in my opinion. I have a number of patients who've had liver metastasis do quite well for long periods of time on endocrine therapy alone, assuming that they didn't have rapidly progressive visceral disease with end organ dysfunction. So the most important prognostic factors are time to treatment failure, especially if prior adjuvant therapy, the site of the disease, visceral or not, and various tumor characteristics still hold true, especially in terms of prognosis, but also in terms of prediction, we'll talk about in just a minute. And I'd like to briefly talk about some new stuff that we've been involved with. It's called Cell Search, and these are data that we published. Massimo Cristofanelli was the first author. We published in the New England Journal about 2 years ago, in which we did a prospective study of 170 patients, 177 actually, who had metastatic disease who were going to start a new therapy, and we looked at circulating tumor cells before they got their new treatment. And what you can see here is that the green line are those patients who did not have elevated CTCs, and the red line are those patients who did in regards to progression-free survival, suggesting that pre-treatment CTCs were highly prognostic. And then we looked at the second set with no monkey business. We said, okay, we've developed our algorithm in the first set, we'll apply it to the second set, and got almost exactly the same results. And we thought that was pretty cool, and now we're trying to figure out exactly how to use that. I would not, at this time, use circulating tumor cells, for example, to bypass hormone therapy and go to chemotherapy. Dr. Cristofanelli does believe that, and he and I disagree. But I think it's an interesting observation, and I think we're going to find circulating tumor cells finding their place in the clinical arena in the near future, and I'll talk about that in just a minute. And then finally, establish the likelihood of response. And of course, Dr. Davidson already talked to you about classic predictive factors, and they pertain in the metastatic setting as well as in the adjuvant setting. And those are ER for endocrine therapy and maybe HER2. There is evidence that HER2 overexpression and amplification may actually result in resistance to either all hormone therapies or perhaps to the SERMs, tamoxifen in particular. For chemotherapy, actually, we've had very few predictive factors, performance status and maybe prior treatment. There are some data that using in vitro assays for chemotherapy sensitivity and resistance might be a thing to do. In an ASCO technology assessment panel, however, they decided that the data just weren't sufficient to make a recommendation on a routine basis for that. And right now, I certainly do not try to send tissue off for chemotherapy resistance. And then finally, of course, HER2 for trastuzumab. And these are the data from the late Bill McGuire, just establishing the whole concept of predictive factors in oncology, particularly related to ER and PR and breast cancer. And there are other predictive factors for chemotherapy. Performance status, of course, is great. Prior chemotherapy. It's not at all clear, though, if prior chemotherapy less than 12 months predicts for resistance to some of the newer therapies like taxanes. The data just have not been published. Most of the data come from the older studies of CMF and AC, suggesting that if you relapse within 12 months, you would be resistant to further treatment with one of those. I think it's likely with taxanes, and likely with capecitabine, and likely with gemcitabine, but I actually haven't seen any data to that. And I talked about in vitro assays, and they're not routinely recommended by the ASCO Ad Hoc Technology Assessment Committee. So these are our treatment algorithms. As you have a recurrence, you initially make the diagnosis, and then you decide prognosis. Either a patient has relatively indolent disease, and most do. If they have a single site focal symptoms, one might choose local therapy in order to get the patient out of pain or to avoid an impending bone marrow spinal cord compression. If they have multiple and rapidly progressive visceral sites, then you might go to combination chemotherapy. But on the most part, I would pick single modality therapy. And if we had systemic therapy, then again, if they're positive for ER and PR and have a long disease-free interval and appear to be responding to the preceding ET, then I would go with endocrine therapy. Again, if they're either negative for ER and PR, a short disease-free interval, or refractory to endocrine therapy, then I would go to chemotherapy. If they're ER positive, we would add trastuzumab, and if they had bone metastasis, we'd add bisphosphonates. Now, once you've made your best bet, was it the right one? And I find that to be one of the most challenging issues in treating patients with metastatic disease, is how long do I stick with the horse I started to ride in the first place? One can use history and physical examination, but they're notoriously unreliable. One can use imaging, but they often take as long as 2 to 3 months to decide whether or not a patient is or is not progressing. And more recently now we have, well, not more recently, we have serological markers, and they are quite helpful, but again, usually only later in a patient's course, and circulating tumor cells. Now, this is an example of a CA15-3 from a patient of mine who initiated therapy, in this case chemotherapy, and over the first 4 to 8 weeks, her 15-3 actually increased to a zenith here, and then began to drop back down again, and ultimately dropped below what it was when she started. This patient was relatively symptomatic here. By 8 to 12 weeks, she was already becoming increasingly less symptomatic, and yet it took her marker a long time to reflect that. Out here, the marker was quite helpful, because with time it began to go up, and she was having symptoms I couldn't quite sort out, and ultimately I decided she was progressing. But the point here is that soluble tumor markers often have this spike, maybe as often as 25% of the time. They can last anywhere from 2 to 8 to 10 weeks and give you a false positive for progression, and the wrong answer for this lady would have been for me to change hormone therapy and go to chemotherapy. Actually, I said I started chemotherapy, I started hormone therapy in her. So we got excited about looking at CTCs. It turns out that circulating tumor cells at first follow-up do not have this spike I just showed you. And so these are data that look very similar to the data I showed you before, except in this case now, we've drawn the circulating tumor cell at first follow-up after starting a new therapy, this blue line. And what you can see here is that time progression is quite short from the time we drew that line. 50% of those patients with elevated circulating tumor cells had progressed within the next month or so, whereas if they didn't have elevated circulating tumor cells, they had a relatively long time to when they progressed. Now, there are two issues about that. One is that most of these patients do have rapid progression if they're on that red line. However, I don't know that changing therapy early, which is a real paradigm changer for me at least, would do those patients any good. Perhaps this is the 20 or 30% of patients for whom no chemotherapy is going to work, and they're just going to go on and progress on everything. Or the alternative is I just started the wrong therapy, they happen to be resistant to that therapy, and the good news is they have metastatic breast cancer, and there are multiple other options to try. The other is some of these patients don't progress rapidly, and I would presume that changing therapy on them right away would not do them any good. So in the Southwest Oncology Group, we're about to open a study. It'll be open on the CTSU, and I would hope many of you would participate in this study, in which a patient with metastatic breast cancer who's going to start first-line chemotherapy, so this is first chemotherapy in metastatic breast cancer, will be profiled with circulating tumor cells. If she does not have elevated cells, you can start her on whatever she's on, and she's not on the study. But if she does have elevated circulating tumor cells before she starts therapy, you pick whatever therapy you want, give her one cycle, and we'll test the cells again at about 3 to 4 weeks after she's had her first cycle. And if she's cleared her cells, and about 20% of patients will clear their cells, then that patient remains on whatever you chose, presumably you chose correctly. If she doesn't clear her cells, though, then those patients will be randomly assigned to staying on what they're on until they have classic signs of progression, which would be standard of care right now, or switching to a different chemotherapy of your choice right then, as opposed to waiting until she becomes symptomatic or until you have classic evidence of radiographic progression. That study is now open. It's available on CTSU. It's going into several IRBs right now as we speak. Now let's talk about some special considerations regarding the treatment of metastatic metastatic breast cancer. The first of those is bisphosphonates. They are clearly here to stay. They clearly reduce bone complications in patients with metastatic disease. And I believe every patient with metastatic breast cancer to bone should be started on some sort of bisphosphonate. I don't believe there's any evidence to suggest that one is better than the other in terms of the intravenous bisphosphonates, whether it's pamidronate or zolidronate. You can't get clodronate in this country. In Europe, it's an oral agent and it's used quite often. One of the questions I get asked quite frequently, though, is when should you start a bisphosphonate? And while I generally say any patient that has a bone metastasis should start, I must say that in the occasional patient, for example, who might have a sternal metastasis only and who is otherwise not going to be on intravenous therapy, say I'm going to place her on an oral hormone therapy, I hate to tether that patient to me with intravenous therapy on a monthly basis, and will probably irradiate that site as well. So that patient, I don't necessarily start on bisphosphonates right away. But if a patient has a distant site or more than one site, then I begin it. I think the second question is, should they be continued after they've had a new complication? And I just asked Gabe Hortabaji, whose name you'll see here, that very question yesterday in Seattle. Actually, it was Saturday. And his answer was, we don't know. We've never tested it, and nobody really knows. And so the default is, since we believe in treating people all the time, 24 hours a day, we usually go ahead and treat people. I personally do continue the treatment from one systemic therapy to the next until the patient ultimately dies. But I'm not sure that's right. In the past, it seemed like all I was costing them was the intravenous therapy and the money. But of course, now we have this new osteonecrosis of the jaw. It looks like it's going to be somewhere between 1% and 5%. There are now registries. Again, Gabe Hortabaji has a registry in press now suggesting that it's as often as 1%. Part of the problem is the definition of osteonecrosis of the jaw, and it's not entirely